Okay, so let's talk about the differences in the anatomy and physiology in children and when it comes to fluid regulation in their bodies. So first of all, we do know that our bodies are made up of a large proportion of water. Our body fluid does have a lot of water in it with electrolytes sort of concentrated in them. The most common electrolytes we're aware of: sodium, potassium, calcium, magnesium, and chloride. Our class lecture will really focus on sodium and potassium. Our fluid is constantly leaving our body, and we do tend to forget insensible water loss, which is the water loss we cannot observe through such things as urine output, but rather is fluid we lose through our skin, through feces, etc. And respirations is also included in that insensible water loss. Basically, when we look at fluid balance, what we want to be able to see is that what we take in orally is approximately equivalent to our urine output. Give or take, it needs to be in that same range. And that the water provided in food and by our body's metabolic processes needs to be approximately, or is approximately, about the same as our insensible water loss. So when we look at the types of fluid that we have in our body, there are different compartments in which that fluid is located. So intracellular fluid is just what it sounds like. It is fluid located inside the cells of our body, and it makes up about 2/3 of the water in our body. And extracellular fluid, that remaining 1/3 of body fluid, is outside the cells and is made up of two different areas. One, inside blood vessels, or intervascular volume, and that volume that is in between the cells, which is the interstitial fluid. And depending on where the water is located or the fluid is located, the concentration of electrolytes may vary. So how does fluid move between all of these compartments? Well, there are a couple different processes. And again, a lot of this should be repetitive for everyone, but I wanted to make sure that we had gone over these things before we got into our lectures about dehydration, fluid imbalances, acidosis, etc. So in terms of filtration, this is when fluid moves from intervascular to interstitial. And osmosis is in and out of cells. Electrolytes, so that's how our fluid moves. In terms of how electrolytes may move, there are two processes. One is diffusion, and diffusion is really based on the concentration factor. So they will electrolytes will move from an area of higher concentration to an area of lower concentration. That's diffusion. There are ways to actively transport electrolytes, and doing that will enable the electrolytes to be transported against a grain of concentration. So it won't matter whether there is a higher or lower level of concentration. So they can move irregardless of that. So in terms of our body weight and what are the demands of fluid on children, and is it different than that of adults? And in a general statement, yes, it is. It is much different in terms of fluid requirements for children. So there is a larger percentage of body weight made up of water in children versus adults. And as we get older, that percentage of water does decrease. So newborn and young infants have a proportionately much larger extracellular fluid volume than older children. And that's because their brain and their skin occupy a large portion of their body weight, and those are made up of primarily interstitial fluid. Infants have a high daily fluid requirement, but have very little reserve. So they have very little, if you will, in the tank to make up for a lack of intake. So they are much more vulnerable to dehydration. It happens oftentimes much more quickly. And in general, infants need about 4 to 5 times greater daily water needs per kilogram than you or I would need. As infants grow and these toddlers 2 years and under, they lose a large portion of fluid each day that is greater than that we would see in older children or adults, and therefore they really do need to have a better intake of fluid throughout the day. They have large body surface areas, and their insensible water loss through that skin is much higher. So as we look at infants and children under the age of 2, they need to have a greater intake when we are looking at them. Respiratory rates and metabolic rates are higher for children. We know in looking at the vital signs of children that they are much higher than that in older children, adolescents, and adults. And thus they do have a lot of insensible water loss through their lungs. So there's a greater water demand to fuel the body's metabolic processes as a result of that increase in respiratory rate and metabolic rate. Exercise in young children can cause them to dehydrate much faster as a result of this difference, and therefore they are at a great risk of dehydration and complications during physical activity, especially in heat. And we'll talk a little bit about that when we're in class this week. This slide just kind of gives a brief picture. This comes from the book, and it really does look at the differences in total body water going from newborn to child and adolescent. And you can see there is a great decrease in total body water because of the makeup of different things as we grow and the proportion at which various organs are involved in our bodies as our bodies grow from infancy to adolescence. So there are some regulatory mechanisms when we have fluid status compromise, and there are a number of those in our bodies. Kidneys is one of the major systems, or our renal system. So kidneys can help us conserve water and electrolytes when needed, and they can help us excrete waste and drugs. However, in young children, and in particular children under the age of 2, infants and children, they have an immature renal and kidney system, and they are unable to conserve and excrete as well as older children, adolescents, and adults can. So that does pose a greater risk for them. More water, as we've said, is generally excreted in infants and young children, and therefore they become dehydrated much more quickly. And in getting dehydrated, they can have electrolyte imbalances much more quickly. Overall, the kidney system, as I said, is more immature and is just not capable of regulating fluids and electrolytes as efficiently as older children and adults do. So when we look at acid-base balance, as a quick review here, when we're looking at acid-base balance, hydrogen ions make up acidic, is an acidic component. So acidity is expressed in pH, and when we draw lab values blood pH, we are really measuring, in a sense, hydrogen ion presence. Our body needs to maintain a good pH in order to allow for optimal cell function and, in the end, optimal health. You can see that our arterial pH varies depending on the age of the child. They are all sort of in the same range of approximately 7.35 to 7.4, 2 or so, but they are generally in that range with slight shifts as we age. Cells in our bodies also just on a normal daily basis produce acid, and so our body must work using its various different systems to neutralize the effect of the acid that is being produced. How do we do that? Is through a system of buffers. Buffers are compounds that either bind to those hydrogen ions when their concentrations are high or release them when their concentration falls. And an example of those would be bicarbonate or hemoglobin are the most common ones we think of. So lungs are also very important in our role of acid-base balance. So lungs excrete carbonic acid. And when we breathe out carbon dioxide and water, which basically is carbonic acid, we breathe off that acid. So faster and deeper breaths will give us a greater carbonic acid excretion. So when we have a state of respiratory acidosis and that carbonic acid is high, we often will see patients with faster and deeper respirations in order to try to blow that off. Involuntary control is what allows our body to make changes and adjustments in our breathing patterns to assist with carbonic acid levels. We have chemoreceptors that pick up not only on pH, but PCO2 levels. Remember, PCO2 is the measure of carbonic acid. So when we draw a blood gas, we are looking at PCO2, which is a reflection of carbonic acid. Our kidneys excrete metabolic acids. So when we are looking at metabolic acidosis versus respiratory acidosis, we are looking at bicarbonate and our bicarb levels. So when we draw a blood gas, we are looking at bicarbonate levels. So the kidneys allow us to either resorb bicarbonate as needed or excrete it depending on what our body needs are. The blood bicarbonate concentration is an indicator of the amount of metabolic acids present in the blood. So if metabolic or if our kidneys are vital to us maintaining metabolic balance in terms of pH, then good kidney function is vital. And so when we look at conditions that cause metabolic acidosis, it's a good indicator whether the patient has good kidney function or not, or has an injury or has taken a medication that in some way has affected kidney function. And it's important for us to think about that when we look at metabolic acidosis versus respiratory acidosis.